Good afternoon, everyone. I'm Dr. John Shrigley, the pathology lead for the Canadian Partnership Against Cancer and a staff pathologist at Trillium Health Partners in Mississauga. On behalf of the Canadian Partnership Against Cancer, Cancer Care Ontario, and the Canadian Association of Pathologists, I'd like to welcome everyone to today's CAP Cancer Protocol education session on vulva, vagina, and cervix. Before I introduce our speaker and we get underway, I'd like to take care of some housekeeping items. Firstly, the session is being recorded, and a link to the recording on CancerView will be circulated to all participants via email when it becomes available. The CancerView website will be upgraded over the next few months. One of the first upgrades is that the CAP education session recordings will now be available on YouTube. We will share you the direct YouTube link to this session, as well as a link to the CancerView page where you can view all previous sessions as well. Both the live presentation and recorded presentation are eligible for CME credits. Information for obtaining credits can be found in the session notice. Please note that the CME certificates for each of the educational sessions will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline date. Please note that everyone's line has been automatically muted for today's presentation. We have a large number of participants and will not be able to troubleshoot Skype for Business issues as part of this call. If you're experiencing technical problems, please call the Skype for Business support line. We encourage you to submit questions at any time during the presentation using the chat feature within Skype. Chat instructions can be found in the session notice. During the question and answer portion of the presentation, a session moderator will pose the submitted questions on your behalf for as long as time permits and in the order in which they appear. In the chat window, please include the following information: your institution's name, the name of the individual posing the question, and finally your question. It is now my pleasure to introduce Dr. Lynn Hoang. Dr. Hoang is a pathologist from Vancouver General Hospital and the University of British Columbia with a subspecialty interest in gynecologic pathology. She did her residency training at UBC and fellowship training at Memorial Sloan Kettering in New York. Lynn has a strong interest in molecular pathology and its application in gynecologic pathology. She's also leading a team to identify new techniques to diagnose HPV-negative squamous precursors in the vulva. She's active in the Canadian Gynecologic Pathology Network and comes very highly recommended by Blake Jilks as one of the next-gen stars in gynecologic pathology. So without any further ado, I introduce Dr. Hoang to give today's talk on vulva, vagina, and cervix. Lynn?
Great. Thanks, Dr. Shrigley. Can you hear me okay?
Yes.
That was a very nice introduction. I paid Dr. Jokes $20 for that nice comment that he said. So, okay, so without further ado, we're going to cover the CAP checklist for the female lower genital tract. So that includes the cervix, vulva, and vagina. And our goals for today are to go over some practical considerations that I hope you'll find helpful when you're filling out the CAP checklist. And then we're also going to touch upon some new topics that are on the horizon for each of these areas. So just so you know, the CAP checklist for cervix, vulva, and vagina, they do not include sarcomas, melanomas, lymphomas, or gestational trophoblastic diseases, as they are covered by other CAP checklists. And the other thing to note is that the current CAP checklist posted online actually include the 2015 FIGO cancer reports, but this is actually slightly out of date. Because there's actually a new FIGO cancer report that was published very recently, just last year in 2018. So we will also cover some of the new changes that were put forth in that publication. So I have to admit this is going to be a fairly information-heavy presentation, given that we are going to go through 3 CAP checklists. So I have included some nice photos of spring for you, since spring officially started 7 days ago, even though it may not feel like it, depending where you are. So if you start to feel a little bit overwhelmed with all the information, you can just close your eyes and imagine some of the beautiful places around the world that you could theoretically be instead of in your office or listening to this webinar. Okay, So we're going to start with the cervix. So for the cervix, the first item on the CAP checklist is the procedure. So this can be a local excision by LEAP, also known as a loop electrosurgical excision procedure. And what this does is it utilizes a loop device to scoop out a piece of tissue with cauterization. And this is usually used for lesions that can be easily visualized on the exocervix and transformation zone, such as squamous dysplastic lesions or lesions that you can easily see with acetyl white application. And then for a cold knife cone, it's a little bit different. For the cold knife cones, the gynecologists actually want to get a little bit higher up into the endocervical canal. So this procedure is usually used for targeting glandular lesions, which can extend higher up in the cervix, such as AIS. So when it comes to specimen handling of a LEAP or cone, you do want to ink the margins. Margins is generally considered optional for LEAPs because most of the time you'll have cautery to help you. But for the cones, you're not going to have that cautery, so you do want to make sure that you are inking your cold knife cones. And then you also have the option of inking the endocervical margin a separate color, but that's really up to you. And then for large LEAPs or cones, you do want to try to open up the cone at 12 o'clock and then pin it on a wax board or a cork board, and usually for at least 3 hours or more prior to sectioning the specimen. Now, the LEAPs and cones are usually received oriented by the gynecologist, and most of the time they put a little suture at 12 o'clock. And then the pathologist can either decide to section radially, like a pie or a cake, or sequentially. And it doesn't really matter what method you use as long as you have a systematic way of sectioning your LEAPs and cones. And then when you submit, you also want to do that fairly systematically. So you're going to submit by either clock face, by quadrant, or sequentially. And then you want to make sure that your sections are fairly thin, so 1 to 3 millimeters in thickness. And it is recommended optimally that you're submitting 1 piece of tissue per cassette, although I do understand there will be some practice variations around the country. And then beyond the excisions, you can get larger specimens, so you can get a trachelectomy. So a trachelectomy is actually something that was pioneered fairly recently by an OBGYN in France, actually in the early 1990s. And this involves basically removing the cervix as well as the paracervical tissue and leaving behind the uterine body in an attempt to preserve fertility. So for approximately 50% of patients who get a trachelectomy will go on to have a successful future pregnancy. So for the trachelectomies, the surgeons are aiming to get a 1 centimeter clear margin. So it's recommended that you basically cut off 1 centimeter or more off the end, ink the margin, and then section radially and perpendicular to that margin. And then you also want to radially submit the rest of the cervix. You can also get hysterectomy, so that's usually a total hysterectomy or a radical hysterectomy. And the difference is that in the latter, in a radical hysterectomy, you're going to get the paracervical and parametrial tissues as well as approximately 1 inch of vaginal cuff. And this procedure is more often performed for cervical adenocarcinomas. And this is really the scenario where you'll get surgeons calling you to say, like, is this a cervical primary? Is this an endometrial primary? Because if it's a cervical primary, they're going to perform a radical hysterectomy. And depending on which surgeon you ask, some will say, once I've done a simple or total hysterectomy, I actually can't go back and take out the parametrial tissue. What's done is done. But it depends on which surgeon you ask, because I have had surgeons say, well, yeah, I can go back and take out the parametria. It's a bit difficult, but I can still do it. But I guess the bottom line here is you do want to try to specify if it's a uterine body tumor or a cervical tumor, because it will help dictate the type of surgery that the patient has. Now, for the radical hysterectomy, sectioning is fairly similar. You want to amputate the cervix, open at 12 o'clock, and then pin it down on a wax board or cork board, and that will give you nicer sections when you submit radially by clock face. So the next item is the tumor site. Note that this is actually an optional item as noted by the plus signs. And the take-home message here is when you're specifying the laterality of the specimen, this is in reference to the patient. So this is the patient's right and left, the patient's anterior and posterior. And then when you're designating the clock face values, that's actually different. That's from your perspective or the examiner or viewer's perspective, so 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. If you end up getting a specimen that you don't see a tumor or a precursor lesion, then you are actually supposed to comment on the adequacy of that specimen, so whether you're seeing both squamous and glandular elements or the transformation zone. So the next item is histologic type. I am going to take you on a fairly fast whirlwind tour because this is a checklist talk and we're not going to have a lot of time to talk about all of these entities in any specific detail, but I will just give you some brief notes. So for squamous cell carcinomas, these are the most common types of cervical carcinomas, and almost all of them are HPV associated. And even though you'll see a lot of histologic types that are listed under the WHO, in general, none of those types really have strong clinical, prognostic, or therapeutic relevance. So they're actually not that important to separate out. The adenocarcinomas are a little bit different. They make up only 20% of cervical carcinomas, but unlike squamous cell carcinomas, they're not all HPV driven. Approximately 20% occur independently of HPV. And I will say that the classification of endocervical adenocarcinomas is very likely to change in the next few years. So we're going to touch upon them very briefly, but just know that they're likely to get reorganized in the next WHO in the next few years. So the cervical usual type or conventional type is the most common type. It makes up 70% of all endocervical adenocarcinomas. And this is the classic type. So it's characterized by mucin depleted glands that tend to look very dark or very hyperchromatic. They tend to have lots of apoptotic bodies and lots of mitoses. And these guys are almost always HPV and P16 positive. The mucinous category is a bit of a mixed bag. So it's a mixed bag of both HPV positive and HPV negative subtypes. And you can see morphologically intestinal differentiation. So you can see goblet cells or Paneth cells. You can see large pools or colloid-like mucin. You can see signet ring cells. And all of these features can actually be seen in HPV positive as well as HPV negative types. So it actually does not help you distinguish between the two. It's really a morphologic classification, not an etiological one. Gastric type adenocarcinomas are gaining a lot of popularity. So gastric type adenocarcinomas are the most common type of HPV negative adenocarcinomas. It has an interesting name, gastric type, because the mucin in these tumors is actually neutral mucin, similar to that you would find in the stomach. And this is different from the acidic mucin that you would normally see in the normal endocervical glands. And even though it's called gastric type, the molecular aberrations of gastric type adenocarcinomas is actually more close or similar to pancreatic adenocarcinomas. So they have an interesting name. And these gastric type lesions encompass really a fairly large spectrum. So this includes benign pyloric metaplasia, lobular endocervical glandular hyperplasia, which is considered a precursor lesion, atypical lobular endocervical glandular hyperplasia with more cytologic atypia, gastric type AIS, which is a fairly recently described entity, and then invasive gastric type adenocarcinoma, which can have a lot of morphologic forms. The classic form was this large, almost plant-like cells with foamy cytoplasm and very rigid borders. And then more recently, people have described cells that are very, very pink or very, very eosinophilic. So minimal deviation adenocarcinoma and adenoma malignum, as well as diffuse laminar endocervical hyperplasia, are also considered under the spectrum of gastric type lesions. So just be aware also that P16 is positive in 30% of gastric type adenocarcinomas, but this does not indicate a high risk HPV infection. It just indicates upregulation of CDK2NA. So just be aware that you can't use P16 to determine these lesions, and you really have to rely on the morphology, or HPV-ish is helpful. Now, villo-glandular carcinomas, so as its name implies, it has villo-glandular or papillary architecture. These tumors tend not to be stromal invasive, so they actually have a good prognosis. I find this entity is a little bit of a cheat because it's actually not allowed to have stromal invasion, so of course, if you use that as a diagnostic criteria, they by default are going to do better than the other types. And then there's the endometrioid, clear cell, and serous carcinomas, which I will fully admit is another fairly confusing spectrum of tumors. So the endometrioid type of endocervical adenocarcinoma, this is an HPV-related tumor, but it is mucin deplete, and it's named because it mimics the appearance of an endometrioid adenocarcinoma coming from the uterine body. But this is actually a very confusing term, so I'd actually discourage using the term endometrioid type endocervical adenocarcinoma because it will inevitably confuse your surgeons or clinicians, and most of us know that our clinicians don't like to be confused. And then we have the clear cell carcinoma in the cervix, and this is the classic clear cell carcinoma associated with DES exposure, which was discontinued in the 1970s. So we're not going to see a lot of clear cell carcinomas in the cervix nowadays, but they still can occur. And then there's serous carcinomas of the cervix, which is another entity that people will debate on. These are almost always associated with HPV. So, people will debate as to whether or not there is such thing as a true serous carcinoma of the cervix. But I think overall, despite all the confusion, the most important thing is to try to rule out extension from the uterine body. That's the most important. Now, for adenosquamous carcinomas, to make this diagnosis, you have to be really convinced that there is both malignant glandular and squamous elements. And you have to be careful that you're not misdiagnosing this. So an endometrioid tumor coming down from the uterine body with squamous differentiation may be confused with an adenosquamous carcinoma. And sometimes you can get these very exuberant, benign, reactive squamous proliferations in the cervix. And again, you just got to make sure that you're not confusing this with an adenosquamous carcinoma. Now, there is a special type of adenosquamous carcinoma. This is called the glassy cell variant, and these are almost always HPV positive. They're made out of large, round cells with large nuclei and prominent nucleoli, but I will admit, sometimes we call this the hippie tumor because it's something that you're generally not going to diagnose unless you live through the hippie ages, and nowadays we don't usually make this diagnosis. For the most part, nowadays people will just call this a poorly differentiated adenocarcinoma, and we don't very often use that term anymore. Then we have our adenoid cystic and adenoid basal carcinomas, which resemble their skin adnexal counterparts. So just a few brief words. So adenoid basal carcinomas are also known as adenoid basal epitheliomas, and that's because they're so indolent and they behave so well that some people feel that they really shouldn't be given the name carcinoma. And then you have adenoid cystic carcinomas, which have the same gene fusion, the MIB-MFIB fusion that is also seen in salivary gland tumors. But these tumors are a bit more aggressive. And then very rarely you'll get your neuroendocrine carcinomas that look very similar to neuroendocrine carcinomas that occur elsewhere. And these guys are almost always P16 positive, almost always high-risk HPV associated. And then mesonephric carcinosarcomas or carcinosarcomas. So if you actually see a carcinosarcoma that is centered in the cervix, you really have to think about a mesonephric carcinoma because there's actually way way more likely that this carcinosarcoma is of mesonephric origin than of Müllerian origin. And if you need convincing, these mesonephric carcinomas are GATA3 positive, and they're actually p53 wild type. So in comparison to the Müllerian type carcinosarcomas that you see in the uterine body, those are typically GATA3 negative and p53 positive or mutant. Okay, so we're going to move on to the tumor measurements. So for the cervix, you have to make sure that you are reporting 3 dimensions. For larger tumors, it is better that you report these dimensions grossly, and then for microscopic or small tumors, it's better to report those dimensions microscopically. And I think it's most important that you choose whichever set of measurements you want to report, and don't report gross measurements and microscopic measurements, because again, you're just going to end up confusing the surgeons and the clinicians. And then for everything, whenever I go through these checklists and whenever I go through these specimens and sign out, I always have magic numbers in my head. So when it comes to the cervix, the magic number is 4, so greater than 4 centimeters or less than 4 centimeters. But you should also know that FIGO in 2018 introduced a new cutoff, so they actually introduced a separate 2 centimeter cutoff. So now it goes from 0 to 2, 2 to 4, and then greater than 4. So microscopic measurements are probably what you more often encounter in Canada because of our widespread PAP programs. So there are 3 microscopic measurements that you are supposed to provide. The first is a depth of invasion, so that's measured perpendicular to the surface. And then a horizontal or longitudinal length, so that's basically parallel to the surface. And there's a third dimension. This is the horizontal or circumferential width that confuses people, but this length is actually not used for staging. Only the first 2 measurements are used for staging, and we'll talk about why that is. So when you measure depth of invasion, this is actually measured from the base of the epithelium that it originates from. And this is important because this definition is actually different for the cervix than it is for the vulva. And so I've given you a few scenarios here. So you're going to measure the depth of invasion from the surface epithelium if it comes from the surface, or invasion from the HSIL or AAS that it is attached to, so that's from here to here in this scenario. If the invasive cancer has become detached, then you're going to measure it from the precursor lesion down to the deepest focus of invasion. And then in scenario D, where there's no obvious surface or precursor lesion, then you're going to measure it basically from the surface to the deepest portion of the tumor. And just a few more examples for you. So again, you're going to measure this tumor from the surface, this tumor from the precursor lesion, and then this tumor, the tumor hasn't actually detached from the precursor lesion, but you can still measure the depth of invasion, and this is where features like paradoxical maturation or desmoplasia become really important. And then when it comes to magic numbers, I'm always thinking about magic numbers. So the magic numbers for depth of invasion are 3 millimeters and 5 millimeters. There are some instances where you might want to report a tumor thickness. And this is particularly true for tumors that are quite exophytic. But if you do report a tumor thickness, you should make it very clear in your report that this is a tumor thickness and is not depth of invasion, because those are different measurements. Now for horizontal or longitudinal length, so this will technically affect staging by the AJCC, and this is parallel to the surface, so it really depends on where the tumor is. And here the magic number is 7 millimeters, but you should know that very recently FIGO 2018 has actually removed the horizontal dimension because they thought it was subject to too much inter-observer variability. And I understand that decision, right? Because for a tumor like this, you can end up measuring the 7 millimeters from here to here. You can decide, well, it's kind of on an angle, so I'm going to measure the tumor from here to here, or maybe, it's a little bit curved, so I'm going to measure it somewhat like this. So there is a little bit of variability. The 7 millimeters is retained in the AJCC and TNM, but just know that FIGO no longer considers this dimension. So the third measurement is a little bit confusing for people, and this is because what if you have a really small tumor, by its horizontal or longitudinal dimension, but it's in multiple blocks. So there is an option to report the circumferential width. You can do it grossly. So when you take a cervix and you amputate it and you open up and then you stretch it out, you can measure a circumferential width. But because there is so much variability when you end up opening the cervix and stretching it out, this measurement is not used for staging whatsoever. And the alternate way of measuring circumferential width is just to determine how many blocks the tumor is in, and then each of those blocks is considered 2.5 to 3 millimeters in thickness. So again, not used for tumor staging. So multifocal disease is not actually explicitly stated in AJCC or FIGO, but the CAP protocol has actually put in a recommendation for multifocal tumors. So in order to call something a multifocal tumor, it has to be separated by one tissue block for which there is no tumor, or it can be on the same block, but they have to be more than 2 millimeters apart. And the main take-home point here is if you see multifocal tumor, you're not supposed to measure the whole length because you're going to overestimate the size of invasion. And you're not actually supposed to take each of those individual foci and then add them all together. You're not supposed to do that either. So you're supposed to consider each focus separately. And this is because a tumor like this is really going to behave like a stage 1A1 tumor. It's not going to behave like a stage 1B tumor if you use these other forms of measurements. So just keep in mind that you are supposed to keep these measurements separate. And just to note the terminology for superficially invasive squamous cell carcinoma, this is a definition that varies by site. So for the cervix, a superficially invasive squamous cell carcinoma is a tumor that is stage 1A1, which means it's less than 3 millimeters in depth and less than 7 millimeters in breadth. When you look at the vulva, the definition is actually a little bit different. It's less than 2 centimeters in size and less than 1 millimeter in stroma invasion. And then when you look at the vagina, there is actually no designated or official definition. So just know that that terminology is a little bit different depending on where you are. So the next thing is tumor grade. For squamous cell carcinomas are graded based on their cytologic features. For adenocarcinomas, some people will grade based on the amount of solid growth. This is sort of parallels that seen for the endometrium. But overall, there's actually no consensus that any of these grading systems are reproducible or provide any useful prognostic information. So, for example, when you think about gastric-type adenocarcinomas, they are almost always glandular, so they're going to be, grade 1 by this convention, but they're very aggressive. And so even though it's a grade tumor, they're going to behave quite aggressively. So the systems don't always work out when it comes to cervical adenocarcinoma. And then you want to report margins. So for a LEAP or cone, there's the endocervical margin, ectocervical margin, and deep margin. And then if you have a larger specimen like a hysterectomy, then you have an ectocervical margin, a radial or circumferential margin, and then a vaginal cuff margin. So you want to report both the status of in situ lesions as well as invasive lesions relative to those margins. And you want to also state the extent of involvement. So for cervix, there is no magical number for how far a lesion has to be considered curative. I mean, in breast there's a designation, in vulva there's a designation, but for cervix there isn't really a standardized distance that you're supposed to be in order to consider a margin officially clear or negative. Lymphovascular invasion is an important item to note. Lymphovascular invasion is interesting because it does not officially change the stage, but it will change management, particularly in stage 1A1 tumors. So for a patient that has a very early stage 1A1 tumor without lymphovascular invasion and with negative margins on a cone or leaf, these patients are actually considered cured. So they won't go on to have any other procedures. But the same patient with a stage 1A1 tumor, margins negative, but with lymphovascular invasion, will be offered more extensive surgery or at the very least lymph node sampling. So lymphovascular invasion is technically quite important. And then for additional pathologic findings, you do want to note the presence of precursor lesions. So I put in this very nice photo because, you know, if you open up almost any GYN textbook, you're going to see this very classic photo of CAN1 that goes to CAN2, which goes to CAN3. But you should know that this is actually no longer recommended as per the ISSVD and LAST, because when you put these photos side by side, it suggests that CAN1 progresses to CAN2, that progresses to CAN3, but that's actually not true. So CAN1 is caused by low-risk HPV, and then CAN2 and 3 are caused by high-risk HPV, like, you know, HPV 16 and 18. So they actually are two separate entities. And so now the recommendation is that you call these lesions L-cell or H-cell, very similar to what the Bethesda does. And then if you're very, you know, you're committed to the 1, 2, and 3 terminology, you're allowed to put it in brackets, and that also appeases the surgeons because they're so used to this terminology, but you're actually supposed to use L-cell and H-cell. So for lymph nodes, the pelvic and periaortic lymph nodes are considered regional lymph nodes for the cervix, and then anything beyond the periaortic lymph nodes is actually considered a metastasis. And so you have to separate that out, and that's actually considered under the M category. Now for staging, I don't like to remember all the nitty-gritty details and numbers for staging, but I do always like to keep in mind what is going to be important that will change stage. So the first item that becomes important for staging cervical carcinomas is whether or not the lesion is clinically visible. So I think this is actually one of the funniest staging systems out there, because if the gynecologist can see the lesion, then it's automatically a 1B, and if the gynecologist can't see the lesion, then it's a 1A. So it's a bit of a peculiar system. I know why it is that way, but it is a little bit unusual. So that's the first item to note. And then tumor size of cutoff of 4 centimeters is considered important. Invasion into the perimetrium is considered important. Invasion into the lower 1/3 of the vagina, and that's important because the lymphatic drainage for the lower 1/3 is actually different than the upper 2/3, so that's why that's a cutoff. And then invasion into the pelvic sidewall or hydronephrosis or non-functional kidney is important. And that is really just a clinical indicator that there is pelvic sidewall involvement. And then tumor going into the mucosa of the bladder or rectum or beyond the true pelvis are other cutoff points for staging. So just to reiterate, the FIGO 2015 staging is no longer up to date. The FIGO 2018 staging is slightly different from the 2015. And the main points to note here is that it no longer considers horizontal span. So that 7 millimeters of horizontal span is actually no longer in the FIGO stage. There is now a 2 centimeter cutoff. So before it was less than 4 or more than 4, but now there is an additional 2 centimeter cutoff. And the other important change that was put forth by the FIGO is you are actually allowed to use radiology to change the tumor size and lymph node status. So if there is radiologic evidence of lymph node involvement, technically that tumor is upgraded to stage 3C. And there definitely was some debate in FIGO as to whether this was appropriate, particularly in countries that have higher rates of infectious diseases and tuberculosis and other things that can cause artifactual enlargement of these lymph nodes. But officially, the FIGO did adopt this change, that radiology can change the stage. And then for ancillary studies, the most commonly used biomarker is P16 because this is a fairly good indicator of high-risk HPV infection. So in order for P16 to be considered positive, you're looking for strong and diffuse block-like staining. And then if you see patchy staining, which I call, either this tiger stripe pattern or the piano key pattern, this is actually considered negative for P16. Okay, so we are going to move on to a couple of new topics for cervix. And if this doesn't interest you, you can think about how nice it would be to be in New Zealand right now. And these are the topics that we are going to cover. So just a few brief words. When you try to apply the 2014 WHO in practice, it's actually fairly confusing. The descriptors are not very specific, and I'll give you a few examples. So for usual type endocervical adenocarcinoma, these are made of mucin-depleted glands. And then for a mucinous type, they are full of mucin, and these can be HPV positive or HPV negative. Then there's an endometrioid type, as we mentioned, and these are considered very, very mucin deplete, but how mucin deplete is sort of variable or up to interpretation, and these tumors are HPV positive. They're not the uterine endometrioid type. And then you have viloglandular type, which is also HPV positive and has nothing to do with endometrioid carcinomas from the uterine body. So it's a bit of a confusing terminology, but it was based primarily on morphology. So recognizing that this was fairly difficult to apply in your everyday practice, Dr. Simona Stolnicu from Romania and Dr. Rob Soslow from Memorial Sloan Kettering in New York got together with 7 other collaborators from around the world, and they decided to come up with this new classification called the IECC classification. And what this does is it actually ends up separating tumors of the endocervix into HPV positive and then HPV negative subtypes, and then subcategorizes them. And this is important because we now know that these non-HPV subtypes actually act more aggressively than HPV positive subtypes. So these non-HPV associated tumors, they tend to present in older women, they have larger tumors, they present at advanced stages, and they have worse survival. And this classification provides some more robust criteria, so it is actually more reproducible than the traditional WHO classification. So just, keep your ears open because things are most very well likely to change in the future, and the WHO classification is very likely to be reorganized. There are a couple of other entities that are probably going to be implemented in the next edition of the WHO. There is an invasive SMILE. So this stands for stratified mucin-producing intraepithelial lesion. It's a very good example of how creative GYN pathologists can be with their naming. I can name a few other entities that are quite creative. So this invasive SMILE is thought to be derived from reserve cells of the cervix. So not surprisingly, they have some hybrid features of squamous and adeno. So they are positive for P53 and P40, usually at the periphery. They're almost always positive for HPV. And each of the cells are filled with mucin. And if you need to convince yourself, you can throw in a PAS, and these will all light up with mucin. There is also a new micropapillary pattern. So just keep in mind that this is not a diagnosis, this is a pattern, because the micropapillary pattern can be associated with various HPV positive and HPV negative subtypes. And when you see a micropapillary pattern, this is associated with increased risk of lymphovascular invasion as well as lymph node metastases, very similar to the micropapillary patterns that you would see in breast and bladder. And then again, if you need convincing, you can throw in an EMA, and you can see this very nice inside-out pattern. So the new kid on the block is also the Vulva patterns of invasion that I'm sure some of you have heard about previously. So for those of you who sign out a lot of leaps and cones for glandular lesions, you will really truly appreciate how difficult it is sometimes to separate AIS from, very early invasive adenocarcinoma, and then how difficult it is to measure that depth of invasion. And I think no amount of Tylenol or aspirin is going to help you with this dilemma. It's quite challenging. So to address this issue, there is another group of international collaborators, and they decided to coin the Vulva patterns of invasion, named after alveolar Sylvia from MD Anderson. So to summarize briefly, pattern A is made out of very well demarcated glands with round contours. You're not allowed to have LVI, but you are allowed to have complex cribiform or papillary growth. And then for pattern B, these are pretty much pattern A tumors, but they have very focal areas of stromal destruction. And then pattern C is pretty much widespread destruction or confluent areas of growth that are more than a 5 millimeter field. So why are the Vulva patterns important? Well, one, in terms of pattern A, it actually makes our lives a lot easier because you're not so pressured to distinguish between AIS and pattern A Vulva. And this is because when you look at pattern A, the chances of having a lymph node met is pretty close to 0. For pattern B, the risk of having a lymph node met is about 5%. And then for pattern C, quite substantial, so over 20%. So the Vulva patterns do translate to some clinical relevance. So pattern A, if a patient has a pattern A tumor with no LVI and margins are negative, patient's pretty much done and considered cured. But if you have a pattern B or pattern C tumor, then you should really consider doing lymph node sampling or a more extensive procedure. And the last new topic for the cervix is the NCCN guidelines. So the NCCN guidelines as of 2019, they have stated that you can do MMR testing or PD-L1 testing for cervical cancer patients with recurrent, progressive, or metastatic disease. And this is based on 2 very early phase 1 clinical trials that have showed a 20% response to pembrolizumab for cervical cancer patients based on a combined positive score of 1% by IHC. I mean, most of these tumors are squamous histology, but there were a few adenocarcinomas in there as well. So just keep this in the back of your mind, because I would not be surprised if down the road one of your oncologists is going to ask you to do PD-L1 on your cervical tumor. So it is coming down the line. Okay, so I know that was a lot of information. So if you want to daydream a little bit, you can think about being in Japan, visiting the nice pink moss flowers that they have there. So we're going to move on to the Vulva CAP checklist. So for the vulva, the specimens can be a wide local excision. So this is used when you have a very local lesion and you want to just get a 1 centimeter of margin. So this is used for 1A tumors, so very early tumors, less than 1 millimeter of stromal invasion, less than 2 centimeters in size. You can also have a partial or a total vulvectomy, and a total vulvectomy is basically a procedure that removes more than 80% of the vulvar surface area. or you can get a radical vulvectomy. So a radical vulvectomy can be partial or it can be complete. And the difference is that for a radical vulvectomy, you're going to remove quite a bit of deep subcutaneous tissue. And most of the times for our surgeons here, they're going to remove the fat all the way down to the pelvic bone. So it's really quite thick and quite extensive. And just a reminder that the same as for the cervix, when you are designating these specimens, left and right, anterior and posterior is in reference to the patient. And then if you're using the clock face, that is in reference to you, so the examiner. So 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. The other thing you want to denote is the tumor site. 80% of tumors will occur on the labia majora, so this is hair-bearing skin, and then with a minor proportion in the labia minora, which is squamous mucosa without hair and adnexal structures, or the Bartholin glands, which are HPV positive pretty much almost all of the time. Then you also want to document the tumor size. And the magic number here is 2 centimeters, and then tumor focality, whether you are looking at a unifocal or a multifocal tumor. And here there's actually no designated criteria of how far the tumor foci have to be in order to be considered separate foci. So you just have to use your judgment in this case. Under the histologic types, again, there are numerous variants of squamous cell carcinomas, but again, very few of them actually have clinical or therapeutic relevance. And then under the adenocarcinomas, you can get a variety of histologic types. That includes mammary, sweat gland type, or adenocarcinomas associated with Paget's disease, and then some very rare neuroendocrine tumors and undifferentiated carcinomas. So again, you are supposed to report histologic grade. And then depth of invasion. So depth of invasion is worth talking about in a little bit more detail because depth of invasion for vulva is different than it is for the cervix. So for depth of invasion, you're trying to measure from the epithelial stromal junction of the adjacent dermal papilla to the deepest point of invasion. So you're measuring from the adjacent papilla down to the deepest point of invasion. So that is actually the depth of invasion. For cervix, it's different, right? You're measuring from the precursor lesion, so you would measure it from here to here. But for vulva, that's not true. You're measuring it from all the way up here, all the way down to the deepest point of tumor. So there is a group from the Netherlands that didn't like this mode of measurement, and understandably so, because it ends up you end up over-treating some patients. So they have proposed an alternative way of measuring depth of invasion, similar to that in the cervix, as opposed to the traditional way, which results in larger measurements. But I'll say that it hasn't fully caught on, and the AJCC and the FIGO have not officially adopted this means of measuring, and partly because all of the established literature in terms of recurrence rates and lymph node rates are based on these traditional measurements, so it's fairly hard to shift over to this new system, even though I do see where they're coming from. And then you do want to measure cometant tumor border. This is an optional feature, so you can have pushing borders like you would see in verrucous carcinomas. So I've heard this been coined as, tumors with baggy trousers. This is the Wilkinson terminology. Or one of my fellows told me, it looks like elephant feet, like big fat elephant feet. Or you can have very destructive tumor invasion, and if you have fibromyxoid stroma, that confers a worse prognosis than your typical just desmoplastic stroma. And you want to mention invasion into other adjacent tissues as well as margins. So for vulva, there is a magic number. The surgeons are looking for a 1 centimeter clearance clinically. And then for pathology, that's an 8 millimeter clearance, and that is because it allows for a little bit of tumor shrinkage with formalin fixation. You should also report lymphovascular invasion. And you should report lymph nodes. So lymph nodes are a little bit different in the vulva than they are in the cervix. So regional lymph nodes for the vulva are actually only considered femoral and inguinal. anything beyond the femoral and inguinal lymph nodes is considered a metastasis, and that is designated separately under the M. So for cervix, right, I mean, cervix goes all the way down from femoral, inguinal up to periaortic as regional lymph nodes, but this is not true for vulva. And I put in a little bit of added detail. If you're curious if a surgeon is going to give you lymph nodes, well, if it's a stage 1A tumor, you're not going to get lymph nodes with your specimen. If you have a fairly small tumor, so less than 4 centimeters but greater than 2 centimeters from the midline, you're going to get an ipsilateral lymph node dissection or sampling. And then if you have a large tumor, more than 4 centimeters and less than 2 centimeters from the midline, then you're going to get a bilateral lymph node dissection. So for lymph nodes, this is a bit confusing, a bit funny as well. So in terms of isolated tumor cells, the definition of an isolated tumor cell is the same as for everywhere else, particularly for breast. So for ITCs, this is less than 0.2 millimeters or less than 200 cells. But there is another cutoff, and that's actually 5 millimeters. So this is considered a clinically significant lymph node metastasis. And again, for staging, I don't like to memorize all of the particular stages, but I do like to think about the things that will change the stage. So that's going to be tumor size, more than 2 centimeters, stromal invasion of 1 millimeter or more, invasion into the lower 1/3 of the vagina, urethra, or anus, invasion into the upper 2/3 of the vagina, urethra, or into the bladder, rectum, or into the bone. So when it comes to lymph nodes, again, whether this is a metastatic deposit that is more than 5 millimeters or less than 5 millimeters is actually an important cutoff. Whether there is extranodal extension also changes your stage, and whether there is fixed or matted lymph nodes will also change the tumor stage. So also keep in mind, so the FIGO 2015 for vulva is actually pretty much the same in the 2018 version. There is a caveat that FIGO wants at least 6 lymph nodes. And if you don't have at least 6 lymph nodes, then technically you're supposed to give it a PTNX. I don't think many people follow this guideline, but just know that, you know, this is what was recommended by FIGO. For AGCC, that's not true. You can just report the lymph nodes no matter what number you have. And then you want to report additional pathologic findings in the vulva. And I just want to reiterate the same thing for VIN as CIN. So again, the terminology for squamous dysplastic lesions is dichotomous. So VIN is no longer VIN 1, 2, and 3. It is now L cell versus H cell. And the other thing that I want to point out is that DVIN, or differentiated VIN, which is HPV independent, VAN, is not the same as VAN3. So I know that some pathologists will say DVIN brackets VAN3 because they want to convey to the surgeons that this is aggressive, this is high grade, but technically you're not actually supposed to use the numeric values for a non-HPV associated lesion, and that is because sometimes your clinicians will see VIN3 and they'll think it's an HPV-driven H-cell. So just so you know, you're not supposed to put in the numeric values in reference to DVIN. Okay, so I know a lot of information, but we are going to talk about some of the new topics in the vulva, which are very likely to change in the next few years. So the first thing to note about vulvar squamous cell carcinoma is that it is not one homogeneous entity. So you have some vulvar squamous cell carcinomas that are driven by HPV infection occurring in young patients with multifocal disease, you know, in a background of HSIL, also known as usual type VIN. And this usually gives rise to warty or basaloid vulvar squamous cell carcinomas. And then there's a separate arm that is not HPV driven, And these come out of a background of differentiated VIN. These tend to occur in older women, giving rise to keratinizing squamous cell carcinomas. And there is some speculation that maybe there is even a third arm, that there are some bad lesions that give rise to verrucous carcinomas, and some of them transform to keratinizing squamous cell carcinomas. So the thing to keep in mind here is, as our country has, these very good HPV vaccination programs, you're going to see less and less of the UVIN arm, and you're going to see more and more of the DVIN arm. And that's also because of our patients are living longer and longer. So, this is something that's difficult, but it's something that we're going to have to face sometime down the road. And even though we treat invasive squamous cell carcinomas like they are one homogeneous entity, they are not. So our HPV-associated squamous cell carcinomas do a lot better prognostically than the HPV-negative squamous cell carcinomas. So even though we treat them the same, we want the same 1 centimeter margin, they are different entities. So when it comes to interpreting biomarkers, P16 is a good biomarker that we use to predict high-risk HPV infection. We're fairly good at using it. So when P16 is negative or patchy, that's considered P16 negative. And then for P16 to be considered positive, you're looking for strong, diffuse, and block-like staining in at least 1/3 of the epithelial thickness. So you don't actually need full thickness staining or 2/3 thickness. You just need 1/3 of the thickness to consider it positive. And even if you have strong staining but it's patchy or block-like, this is considered P16 negative. You really need strong confluent staining to call it a P16 positive tumor. So I want to take a little bit of time to show you how to interpret P53 in the vulva, because I think a lot of pathologists are really good at interpreting P53 in high-grade serous carcinomas, but for some reason we're very bad at interpreting P53 in the vulva. So I'm going to give you my own special crash course to P53 in the vulva. And this is important because you can actually use P53 to help you diagnose DVIN if you know how to use it properly, because over 90% of DVIN will have P53 mutations. So the first thing to note is for normal skin, you're going to see patchy P53 staining in the basal layer. So again, another example, very patchy staining in the basal layer. And you should know that you can get a lot of parabasal P53 staining, and that is okay. That does not mean that it's mutated. You should always try to look at that basal layer. And lesions like this will have a lot of parabasal staining, but again, that basal layer is not staining. So, these are patterns that you will see in reactive lesions or non-neoplastic lesions. So you can see this in psoriasis, spongiotic dermatitis. You can see this in usual type manner H cell, and this is not a P53 mutated pattern. So most importantly, you want to look at that basal layer, and if you're lucky, you're going to see a lot of parabasal staining. So this is an abnormal mutated pattern. And again, you don't have to have a lot of parabasal staining, but you really want to look for that continuous staining at the basal layer to call a P53 abnormal or mutant pattern. So you can have wild-type P53 pattern in vulva, overexpression or mutant pattern, or even this null-type pattern. Of course, you have to look for your good internal positive control. And there's another pattern to look for. So this is a cytoplasmic pattern. And the very first time that I saw this pattern, I actually thought that somebody messed up the specimen or messed up the stain. This is the same P53 in the invasive squamous cell carcinoma. And then when you actually look at the adjacent normal skin, there actually is nuclear staining of P53. So this is actually a true mutated P53 pattern. And is a mutation that affects the cytoplasmic to nuclear transport of the P53 protein. So this is a mutated pattern. So just keep in mind that there are 4 patterns of P53 mutations. You have a wild-type pattern, your all or none pattern, and then the cytoplasmic pattern. And some other helpful hints when you're interpreting P53 is the abnormal P53 likes to spare hair follicles. Because, when I interpret P53, I always like to look for the adjacent normal skin, and I'll ask the surgeons or the gynecologists to take the junction of the lesion, and they always laugh at me because they're like, I don't know where the junction is. The whole vulva is red. How do I know where to biopsy from? So, point well taken. And if you have hair, it's actually a good, internal control for you to look at what a normal P53 looks like. And P53 usually has a very sharp interface. That's not always true. I have had lesions where we have had this P53 signature go all the way to the margin and the skin looks entirely normal. So I will say this is something new, and we don't really know what to do with patients that have this P53 signature that goes to margin. Whether they need to be resized or not, we don't really know at this point. And when you do P53, it actually changes the margin status in 30% of cases. The majority of these cases are really just DVIN that were missed at a margin, and then the minority of cases are due to that P53 signature. So I'm going to say the last thing about vulva I want to say is we're very terrible at it, I'll fully admit. We're really good at diagnosing HSIL. We're really good at diagnosing DVIN that is very ugly, so this, anastomosing Metu ridges, big cells with basal atypia and nuclear atypia, but we're really bad at diagnosing squamous precursor lesions that don't have full-fledged features of DVIN. And I want to give you an example. So this is an 84-year-old patient with a long-standing history of vulvar squamous cell carcinoma and DVIN. And obviously she has a lesion. It is very, very thick. The reedy ridges are very long, but there isn't actually a lot of cytologic atypia. You do your P53 and it's patchy, it's wild type. So, what are you going to call this lesion? And a lot of people have coined a lot of different terms. My favorite term is this DEVIL, this differentiated exophytic vulvar intraepithelial lesion. But I have heard people, I did review a manuscript recently that was saying, it's a great term, it's very catchy, but I can't imagine ever saying this to a patient that, you have a devil and we need to excise it. I mean, I admit it's very catchy, but maybe not the most appropriate for clinical use. So, what we're going to call these P53 wild-type squamous lesions will change in the future, and we'll have to sit down and sort it all out. So same patient, she does have another excisional biopsy and a background of lichen sclerosis, and again, a very thick lesion in the vulva. It's got some irregular rete ridges. The atypia is there, but it's not super striking. Maybe it is. And you do your P53 and it's abnormal. Not as abnormal as you'd like it to be. You probably want a little bit more pair basal staining, but it is confluent and continuous in the basal layer. So, what are you going to do? Is this a DVIN? Are you, can you just base it on the P53, or are you going to call it something less? So again, this is a P53 mutant squamous precursor lesion, and we'll all have to sit down and figure out, what we are eventually going to call these lesions. So the last thing we're going to talk about is vagina. It's a fairly quick overview because these are very rare tumors. You do want to comment on the procedure, whether it's an excision or a vaginectomy. And then in terms of grossing, you want to take sections of this in relationship to the cervix and paravaginal tissues. And most importantly, you just want to make sure that this is not a tumor that is coming out of the cervix. Tumor site is very important in the vulva, as I mentioned previously, and they're separated into thirds for a reason. So the lower 1/3 of the vagina will drain into the inguinal and femoral lymph nodes. So surgeons want to sample. This is where they're going to sample from. If the tumor is in the upper 2/3, it's going to go into the pelvic and para-aortic nodes. So this is why there's this separation into upper, middle, and lower 1/3 for the vagina, and the same cutoffs that are used in the cervix and the vulva. Then you want to mention the tumor size with the same magic number. It's 2 centimeters. It's the same as the vulva. And you want to mention the histologic type. Most are squamous cell carcinomas, as well as the histologic grade. Involvement of other tissues, margins, again, for in situ and invasive disease. The margins for vaginal tumor are the same as for a vulva. They want a clinical clearance of 1 centimeter, but they don't actually give you that 8 millimeter of microscopic or pathologic clearance, and I think that's just because the vaginal tumors are so rare that they haven't published an official 8 millimeter recommendation. And then you can have lymphovascular invasion, which you want to report, and lymph nodes. So lymph nodes are the same as for the vulva. So inguinal and femoral lymph nodes are considered local or regional nodes, and then again, anything beyond that is considered a metastasis. And then you want to just document any additional pathologic findings like squamous precursor lesions. And then for staging, I approach staging the same as the others. I don't like to memorize everything, but I do want to know the cutoffs. So it's a 2 centimeter cutoff, invasion into perivaginal tissues, invasion into pelvic sidewall, or into the bladder, rectum, or beyond the pelvis. So I think that is it. So we have officially, in a very whirlwind tour, gone through the CAP checklist, vulva and vagina, and thanks to all of you who have managed to stay this long online. And with that being said, I am happy to take any questions.
Thank you very much, Lynn. So we're taking questions in the chat box on the left of your Skype window. We have one question so far from Dr. Anna Plotkin. She asks, how do you measure the horizontal extent circumferential in the multifocal disease? Would you suggest to put NA in this situation?
Yeah, that is a good question, and I think it depends on how organized you are. I mean, we try to orient everything so that we can piece it back together. So if you know that this particular focus is seen in 2 or 3 blocks, then you can add up the dimensions and give it a 9 millimeter circumferential dimension. But with that being said, and you're not sure that you can know which foci belongs to the same focus in an adjacent block, then you can put NA, because I mean, in reality, I'm a lumper, not a splitter, so the circumferential dimension is not going to change anyway. So if you're not sure, you can put NA, that's fine.
Great, thank you. I can see people typing questions now, so I'll just give them a second. You got a kudos from Arjuman Hussain for an excellent presentation.
Thanks, I love kudoses.
And Zoray Asmali says there was good discussion regarding using P16 IHC. What is your recommendation? Sorry, that was a good discussion, period. What's your recommendation for using P16 IHC? It was a discussion in US at the 2019 US CAP.
Yes, I was there for that lively discussion about P16. Okay. Yeah, everyone has a different take on P16. Some people love P16. They feel like we should just put it in the water and then everything should just have P16 done on it. So, you know, it all depends. I'm pro P16, so I do like to use it according to the last guidelines. So I'll use it to distinguish between a reactive lesion versus HSIL. The only thing is, I work with Dr. Clement, and we don't usually use P16 to distinguish between L cell and H cell. There are some L cells that are strongly P16 positive, even though when you look at it morphologically, it looks like an L cell. So we do try to go for the morphologic diagnosis, but I will put in a comment that, you know, P16 is strongly positive, and it probably will behave more aggressively than the usual L cell. Whether or not that's right or wrong is sort of up for debate, but I guess I'm going by tradition. But yeah, I do use P16 a lot, and I think as long as you know how to interpret it and in what context, then it's really helpful. I mean, like, for high-grade serous carcinomas of the ovary, I actually like to do P16 because P53 can be positive in a lot of tumors, but if you see P16 and P53, you know, it's probably a high-grade serous carcinoma. So yeah, that's a good question, and yeah, definitely a lively discussion at the SCAP.
Excellent. Our next question is from Amir Samani from Brampton. What's your experience with P16 negative HSIL in cervix? How do you report it?
So these do exist. This is a very good question. So there are P16 negative HPV-driven lesions, and part of usually it's due to loss of heterozygosity or methylation. You're not going to see the P16, but if you are convinced that it is H cell and your P16 is negative, you have a couple of options. I would probably just call it anyway, if you know, because if it looks like H cell, if it looks like a duck, you know, call it a duck. And if you do get stuck and you're not really sure, you know, you can also do HPV-ish. So the new RNA scope is actually pretty good. It doesn't have all the high-risk HPV types. It only has 18 in the high-risk probe set. But if you do get stuck, I mean, that's one option that you could go for. And you might have to send it out depending on the lab, because I don't think a lot of labs across Canada have it. Yeah.
Thanks. The next question is from Melissa Hickey from Horizon, New Brunswick. Does positivity in the lower third Does positivity in the lower third with P16 in a cervical specimen equate with high-risk lesions, or is it HSIL?
I guess they're related. So positivity in the lower 1/3 is sufficient to call it a P16 positive lesion. So I guess, and theoretically, by default, it is considered an H cell, but maybe I'm not fully interpreting the question. So yeah, if it is at least in 1/3, then it is considered positive, and if you are convinced that there are enough dysplastic features, then you can call it an H cell. But most of the time, you're actually not going to see that lower 1/3. You're going to see a lot more. It's just in a few rare cases that you might have some troubles with interpreting the P16.
Thanks. The next question is from HHS. Do you recommend using P53 for margins?
Oh, such a good question. So right now, so we have a good study set. So what ended up happening is, you know, we were trying to stratify our HPV-independent squamous cell carcinomas, and we'd throw P53 onto the tumor. And then inadvertently, by accident, we noticed that the P53 abnormality actually went beyond the tumor and sometimes to the margin. And from what we have right now, there is actually no prognostic difference in terms of a P53 positive margin versus a P53 negative margin in normal skin. So like this P53 signature, there is a trend towards increased recurrences. We have P53 signature at a margin, but right, it's not statistically significant. So we're actually in the process of pulling more cases. I hope my fellow's listening because, you know, she'll pull them faster. So, but right now I would say I wouldn't put on P53 to assess the margins unless you were unsure if there was a squamous dysplastic lesion, like maybe a DVIN or features that morphologically fall short of DVIN and you're not really sure, then I would throw on a P53, but I wouldn't do it just to assess the margins in what looks like normal skin, at least for now.
And do you equate mutant P53 staining as DVIN?
That is a good question. So this is a question that is up for debate. Right now, that's sort of how people interpret it. It's, you know, a DVIN has abnormal P53, and because DVINs have a lot of cytologic atypia, you know, is it allowed to have are you allowed to have DVIN that is not P53 mutated? Is that allowable? Is a question that's up for debate. And then the other question is, well, if it's a squamous precursor lesion and it's not P53 mutated, then what are we going to call it? We're going to call it a devil, or we're going to call it a VAD, or we're going to call it, you know, verruciform hyperplasia. So right now we don't actually know, and the terminology is fairly widespread. So I think we'll sort it all out in the future, but the terminology right now is kind of all over the place.
Thank you. The next question is from Leanne Woodjanarko. Do you use Ki67 to differentiate H-sil, H-H-sil?
I don't. I know some of my colleagues do. They actually use Ki67 for L-sil and for H-sil. And how it helps you again is to look for that reserve cell layer. And if that reserve cell layer at the very bottom is positive, that is much more likely to be an L-sil or H-sil versus some reactive lesion. And I've done Ki67 on a lot of reactive lesions. So I've done it on psoriasis and on spongitic dermatitis and all of these entities. So I know what it looks like. So if you're comfortable with using Ki67, it can be quite helpful. I know my colleagues do it, but you just have to know how to interpret it, basically.
Thank you. This question is from Zora Islami. Do you recommend using PD-L1 and MSI testing in cervical cancer? I thought there were different options on using which kind of PD-L1 in the US CAP in different organs.
Yes, that's a good question. This is a very new topic. So there are actually, you know, there's a very large study of cervical adenocarcinomas, cervical carcinomas that came out of Stanford a few years ago that looked at MMR, and almost none, like virtually none, will have MMR abnormalities. With that being said, I do have a very, very recent case. What I said to my fellows, like, no way is this a cervical tumor. It's probably just a funny LUS tumor because it has loss of MLH1 and PMS2. And then we actually did the HPV-ish, and it was actually positive. So there are very, very rare endocervical adenocarcinomas that have MMR deficiencies. They do exist. They're just very, very rare. So, you know, would I recommend doing it universally? No. You know, if the clinicians are reaching for a patient with advanced stage or advanced recurrent cervical cancer in a patient, you know, I can try doing it. I wouldn't refrain from doing it. Just the chances of doing it are very low. Now, in terms of the PD-L1 question, it's a really good question because, you know, there's a very funny cutoff that we have all just decided to use, which is a CPS score of 1. And I think it's a very low threshold that, came from lung and it has just trickled down to all these other organs. But, 1, is that cutoff appropriate? Hard to say. There's only been 2 trials. And then 2, which antibody are you going to use? Well, in the clinical trials, they use 22C3, but I know there are lots of clones out there. So I don't know if there's a really good evidence-based answer to your question. Which antibody do you use? Do you use the same one in the clinical trial? Do you cut off? They're all good questions. I don't know how it will be implemented down the road, but I would not be surprised if somebody asked you down the road to do the test. So it's a bit tricky, I'll fully admit.
Great, thank you. Those are all the questions that are in the chat box. You have another few minutes if you have a last minute burning question to type it in. And I'd like to turn it over to Dr. Shrigley to close. Oops, I think we just lost Dr. Shrigley, so just wait one moment as he reconnects. And this is your, oh, here is, oh no, that's the same question. We have another question. It says, do we have access to this presentation? And a compliment for Lynn that it was a very nice and complete presentation. Thank you. Yes, this presentation will be available on the CancerView website. We'll be sending out a link to that in the next day or two. Dr. Shrigley, would you like to close us off?
Sure. Thanks, Shelley. On behalf of the Canadian Partnership Against Cancer, Cancer Care Ontario, and the Canadian Association of Pathologists, I'd like to really thank Dr. Lynn Hoang for a great presentation today. I particularly like those lovely pictures, spring pictures of all those flowers you showed as well, in addition to the academic information. As a reminder, both the live and recorded presentations are eligible for continuing education credits. In order to receive your certificate of participation, please provide your name and email address at the link included in the session notice. Here you will also find an optional session evaluation form for which we encourage you to complete. The information collected through these session evaluations allows us to ensure that these sessions continue to be informative and relevant to your practice. We appreciate your feedback and suggestions. Please see the session notice for more information. Just to remind everybody that the next session is next week, April the 3rd, and Dr. Dina Eldelmalawi is going to be talking about the synoptic reporting of hepatoblastoma. So look forward to seeing you at that or hearing from you at that meeting as well. Bye for now.